All right, well, thank you all for coming. It's good to have you here, and it's good to have Mark Elkins here as well to speak to us today on the topic of how to get the most out of health information on the internet. Given the topic of the day, I thought in order to introduce Mark, I would Google him, and I thought that would be appropriate. Anyway, Mark is Canadian, American, English. He's from New Zealand. He's also Australian. He's a master plumber. He's served in Afghanistan, and he's a fashion designer. I think the name Mark Elkins sounds pretty appropriate as a fashion label, don't you think? I'm wearing Mark Elkins. I think you look good enough to be a fashion designer, Mark. Anyway, none of that's true. I've just made it all up. But I guess, I guess I'm just driving home the point. You know, how do you know what you are looking at on the internet is true? Is it authoritative? Is it just internet graffiti? If it is true, how do you know that it's the piece of information that you need and that it relates to you? And where do you go to find information that's easy to understand and reliable? And Mark will be speaking about that. Let me introduce Mark. This is the real Mark. Mark is a research physiotherapist at the Royal Prince Alfred Hospital in Sydney, Australia. His research interests include physical and pharmacological therapies in respiratory disease, coordinating these therapies to maximise their overall effect, and the promotion of evidence-based physiotherapy. Currently, Mark is the scientific editor of the Journal of Physiotherapy and a co-director of the PEDRO online database of high-quality research in physiotherapy. Ladies and gentlemen, please welcome Mark.
So thanks for the invitation to present. I have a couple of disclaimers to start with. The first is I can't get the... There we go. I will be talking about various bits of evidence on the way through the talk today, and I don't want you to take them away and think, okay, I have to apply this to my own management. I'm just using them as particular examples of finding evidence. So I'm not pretending that I'm showing you the best or ones that you should necessarily apply to your own situation. So always talk to your team before you make any changes to your management. I am a physio, so the talk is going to have a bit of a physio slant to it. And the third disclaimer is that although I'm going to slag off a few countries during the talk, I'm actually not a racist person. I just have to say some bad things about some particular countries on the way through. Okay, so what are we going to be talking about? Why you might look for healthcare information online, and when you start doing that, how do you know if a website is trustworthy? And then how do you recognise good research when you find it? What tools are available to help you find it quickly and easily? And how can you get, if you're really interested in a topic and you want to read the actual research that's behind the topic you're interested in, how can you get copies of the papers in full text and not just a little one-paragraph abstract summary of them? And how can you get research that's not published yet? And where can you find trials that you could participate in? So they're all the topics we'll be covering. So why would you look at health information online? Well, one is, particularly if CF is a new diagnosis for you or someone in your family, then you might just be interested in more general information about CF. And the internet is fantastic for that because that information doesn't change particularly quickly. And so you can go to Google, which gave you that very accurate introduction about me, and you can look for sites that you might choose, but you don't want inaccurate information. In fact, I found it pretty hard to find inaccurate information about CF as just background things about the disease, like how common it is and what parts of the body it affects and that sort of thing. So you could look at a national association like CF Australia or CF New Zealand, and you can look at Wikipedia. Now, Wikipedia has had a bad reputation at times where people have said that, people get on there and deliberately falsify bits of information in some of the records and say that Richard Gere was killed in some, climbing accident and whatever, and it all turns out to be a lie. Speaking of which, famous people dying, did you just hear that Willie Nelson died, which I think is really sad? He was hit by a truck. He was singing on the road again. Did anyone fall for that at the beginning? Yes. So you're the people who need to be here because I'm going to talk about untrustworthy websites, all right? But if you go to Wikipedia, actually I found all this information fantastic and accurate, and the thing I like about it is if you're reading and you strike a word that you don't know, then you can click on it and drill down to find out, okay, what's the intestine, what's the epithelium, and get an explanation of that. But for some people that's hard work because just about every word in the sentence is one that you need to go and look up. So you can go to somewhere like a CF National Association, and they have fantastic, the CF one the New Zealand one I love, has great range, how it's diagnosed, what the symptoms are and so on, so you can go through like that. So in general, for that sort of background, the only thing that I found got out of date with finding this background information is the prognosis, because the prognosis for people with CF is improving all the time. So unless the websites are updated, that gets out of date. But otherwise, most of that stuff was pretty accurate. But when you're looking for that sort of information or any sort of information, how do you know a website is reputable? Well, these are the sort of rules of thumb that most of the major government associations and when people write articles about the accuracy of information on the internet, these are the general principles that they come up with. So the website should be linked to a reputable organisation like a university or a government department, and it should be reviewed and updated regularly because, as I'll show you in a minute, the amount of evidence is expanding so rapidly that unless it's updated regularly, it is likely to be wrong just by being out of date. It shouldn't be trying to sell you something. It shouldn't be claiming to advise you individually. It should talk about, in general, people with this disease get this response from this treatment, for example, but it shouldn't be saying you should use this treatment because it will do this for you, because how can it know your individual state? You're just an internet user as far as it's concerned. And it shouldn't use testimonials. That's an absolute giveaway because that means the intervention doesn't have any evidence, and so they have to rely on comments from individual patients to claim that it's good. So generally, if you just want basic information, you can't go too far wrong, particularly if you use those rules of thumb that I just showed you. Other reasons people use the internet when they were surveyed, they said to get a second opinion. Now, I think if it's about your individual care, I think if you want a second opinion, that's fine, but go and find another dietitian or another doctor or whoever who can give you a true second opinion about your individual case. But trying to get a second opinion from the internet I don't think is a particularly wise strategy because it can't be tailored for your individual health state. But sometimes you might say, oh, well, the physio in Christchurch told me that I should do this, and now that I've moved to the Auckland clinic, the physio here is telling me that I should do that. How do I know who is right? And so you might be interested in looking for health information online to try and resolve the conflict between two healthcare professionals that are advising you. Or you might just want to find out about new treatments. And these three all kind of have underneath them a bit of an assumption that someone in your CF team isn't up to speed and doesn't know everything that they should know. And that's fine. In fact, you can't really blame them because when you look at the number of papers published in cystic fibrosis over the years, it doubles every decade and we're up to 40,000. So in 10 years' time, that's 80,000 papers that we're all expected to have kept up with. It's an incredible amount. So it is quite possible that people in your team don't know absolutely everything. And you think, well, they don't have to know everything. They only need to know about dietitian or physio research. Well, even the physio research, it's even more scary because it's doubling every 3.5 years. So we're already up to 14,000. Well, that was in 2010. And in fact, on the physio evidence database, the PEDRO database, if you take this graph out to 2013, it's up to 25,000 now. So there's an incredible amount of expanding evidence in all of the disciplines. So it's quite possible that people in your CF team haven't kept up with absolutely everything. So if you think you've found something legitimate, it's good to raise it with them and ask their opinion. It's scary for me because this is when I graduated, and so the stuff I learnt at uni was about 5% of what's currently out there. So, and even if you've got some perky young physiotherapist who graduated in 2010, they only know half of what's out there now. So this is why members of the team may not always know everything. You may also be interested because you want to find out about alternative treatments. Now, it's funny to think about the definition of alternative, but for most healthcare professionals who try to be evidence-based, I guess it means ones that don't yet have a lot of evidence. And that doesn't stop people from claiming that they are very effective. And the one that probably blights my in-tray every week is the salt cave, because I was involved in hypertonic saline research. And if you apply that test that we saw, so this is basically you go and sit in a room which has salt all down the walls, mounds of salt on the floor, and you sit there for a few hours, and they have a dry powdered salt sort of sprinkled into the air conditioning, and bits of dry salt supposedly float around in the atmosphere and improve your breathing. And they say, well, if hypertonic saline works, then you should just sit in this room for a couple of hours and you'll do well. Well, let's have a look at our rules of thumb. So it's a commercial website, so it's .co, and there are prices, so they are trying to sell you something. It's not really linked to a reputable institution, so the institution's called Breathing Solution, and not really linked to a university or a government department. There are testimonials, in fact there are lots of testimonials, and you can read even more testimonials, and it hasn't been updated since 2009. So the evidence is increasing exponentially, and as far as these people are concerned, nothing new has happened in the area since 2009. So it looks dodgy on just about every criterion on our list. So by all means discuss it with your team, but if this is the sort of evidence you're bringing to them, then you can expect that they can say, look, until there's evidence to back it up, and there's no evidence available on this site, we would be pretty suspicious about it. And one thing that nobody mentioned in a survey of why they look for health information on the internet was to find clinical trials that are ongoing in your area that you might be eligible to enrol in. And I think that's really sad, because there is information about that on the internet, and I would strongly encourage you to, I'll be showing you towards the end of the talk how to find those as well. Okay, so we've sort of covered the first two, but we will touch on them again. But how do you recognise good research when you find it? And I'm going to get a little bit technical and nerdy and scientific for a while here, but we will get a bit more easy to understand once we get over this little hump. So don't lose me, don't walk out. How do you recognise good research? There are all different types of research. There's prognostic research and looking at the prevalence of particular conditions, how common is sinusitis in cystic fibrosis, for example, or what's the life expectancy of people with CF, that's prognostic. But what most people seem to be interested in is, what about this new treatment? Does this treatment work for me? What are the effects of this new treatment? And so that really should be based on a clinical trial, if that's the sort of question you're asking. And the reason we like randomised trials is because you take a group of people with CF and you line them up, and one at a time you sort of flip a coin and you go, right, you're in the treatment group, you're in the control group, treatment, control, treatment, control. Whatever the coin says is where the person ends up. And the beauty of that is you get two groups that have the same characteristics. And so if you then follow them up in a month's time, you would expect them to have similar outcomes, because there's nothing systematically different about them at the beginning. But if only one of the groups gets the treatment and the other group doesn't, and they end up different at the end of the trial, then whatever the difference between the groups is, you can say that was probably due to the treatment, because there was nothing else different between the two groups. And that's what randomisation is all about. It's the only way to get evenly balanced groups. Unfortunately, patients tend to be incredibly lovely people who really like their physiotherapists and want them to have successful trials. And so if you ask them, if they know they're in the treatment group and you ask them, how do you feel? They'll say, oh, Mark, I feel so much better, because they know that's what they ought to say and they want the trial to be a success. Unfortunately, that kind of screws up the trial, because it can make a treatment look as though it's effective when really it isn't, and we don't want to use it for you if it isn't effective. So if you're blinded and if I'm blinded, then neither of us can influence the answers you give. I can't sort of, you ask me, if you say, oh, I'm a bit borderline on this question in the questionnaire, I go, oh, say it better, choose the good one. If I don't know which group you're in, I can't influence you either. So blinding is good. Some treatments are a bit hard to blind, so not all trials are blinded. But if you find one that's blinded, that's a good thing. You also don't want dropouts. So if you have a whole lot of people in this group who do well, but some who do incredibly badly, and they drop out of the trial and you don't measure them at the end, then it makes this look particularly good when in fact you should have measured everyone and said, well, on average it's not that good. So dropouts are bad, and so you want few dropouts, or they also call it loss to follow-up. And the group should be comparable at baseline, and they just about always are. There's usually the first table in any paper is a table of characteristics of the two groups, and you can compare the average age and the average how fat they were and how good their lung function was and so on. And they're just about, because randomisation works so well, they're just about always well balanced. And then there's two really technical terms that I'm going to try and, well, not bore you with. I've tried to make it entertaining, but you will see them mentioned in papers, and they're good things. If you don't understand them, these explanations that are coming, don't worry. It'll only last 5 minutes or so, but I think they're pretty cool things, and so I've tried to explain them in with characters, with patients that you might understand. And they're all to do with characteristics of the patient. So the first one, let's say we're doing a trial, and so we have our list of patients lined up ready to be randomised into the trial. And let's say I'm the person enrolling them in the trial, and I have a random list on the paper, on a piece of paper in front of me that says treatment, control, control, treatment, control, treatment, 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 control, randomly down the page. So that should give us two randomly allocated groups with equal characteristics, right? So here's our list of, here's our line of patients waiting to enrol in the trial. And it's a trial of kryptonite therapy, okay? That's very important. So Yogi Bear comes up and I say, well, this is the trial. You either get randomised to kryptonite or placebo, and you come for measurements twice, and, are you interested? And Yogi says, I can't do the voice, but he says, yes, I'll be in it. And so you flip the coin and he goes into the treatment group, and, okay, that's all fine. And then Josie comes along and you say the same thing. It's kryptonite or placebo, two measurements that you have to come in for. Are you interested? And she says, yes. So you flip the coin and she goes into the placebo group. And then Superman comes along and you just think, I can't quite put my finger on it, but I just don't think he's going to do very well in the treatment group. And so instead of giving him the same explanation that you gave everyone else, you say, oh, this is very hard work, this trial. You have to come in for 2 visits. You can't possibly miss it if you're off rescuing somebody. You have to be here. If you can't make the commitment, we don't want you to be in the trial. You play up the bad elements of being in the trial. And so, because you knew that the treatment coming up was to the kryptonite group, and so you talk him out of being in the trial. Or if it's in the control group, then you just give him the same explanation as everyone else, and you let him go in. And if you do that systematically through the whole list, then you'll end up, randomisation should give you balanced groups. And if you look at all the other factors, like 1 animal and 3 human beings in each group, and 1 person with most of the factors are balanced. Okay, so the gender balance is about as balanced as it can be, and most of the things are balanced, but all the super people, the kryptonite bad responders, all ended up in the control group because we systematically, whenever they were going to be randomised to the treatment group, they ended up in the other group. And that's because I could see the list in front of me. But the list, if the list is concealed in envelopes, or if I have to ring someone to say, okay, Superman's in the trial, which group is he in? And then they tell me, I can't push them systematically towards one group. And so when you see in a trial that patient, don't worry about all this, that there was telephone or off-site randomisation, that there was sealed opaque envelopes with the randomisation list, and you open patient number 5, you open it up and it tells you which they're in. Or if you flip a coin after they're enrolled, but that's, it's a big temptation to reflip the coin, so I'm not particularly convinced by that one. Even opaque envelopes, I have my suspicions about, unless they're truly opaque. But that's one thing. So if you see concealed allocation, you know that these researchers were trying to do everything absolutely perfectly. And the other one is intention to treat. So we're halfway through the nerdiness, I promise. Intention to treat analysis is also about characteristics of the patient. So most patients are just average, all right? Some patients are super keen and enthusiastic, and every treatment you give them, they do it no matter what, and they're in there flogging themselves, doing the treatment to death. And some are not like that at all. They're particularly lazy. And if you randomly allocate your patients at the beginning of the trial, then your two groups will have roughly equal balance of the average people, the enthusiastic and the lazy, all right? And then you give them either treatment or control. And let's say the treatment in this particular trial is inspiratory muscle training, trying to make your respiratory muscles stronger. And so in this group, the enthusiastic people do the exercise and the average people do the exercise, but some of the lazy people don't do it. So they were meant to do treatment, but they actually did nothing, which is what the control group was meant to do. And here, these people were quite happy to do nothing, and these people did because they were told. And these people were just too enthusiastic and too excited, and they love exercising, and they read up all about inspiratory muscle training on the internet, and they just couldn't help themselves, and they did the training when they weren't supposed to. So what do you do with those people? Do you leave them in the groups where they are, or do you swap them to the opposite group? Who thinks swap them? Who thinks leave them where they are? Okay, good. And the reason, a few people did say swap, and the reason you don't swap them is because if you do swap them, this thing's driving me nuts, then you end up stacking this group with enthusiastic people and stacking this group with lazy people. And let's say the treatment does nothing, okay? Exercise has no effect at all. What you might see is the outcomes in this group are better because these are the ones who also take their nebs and take their enzymes and do all the other things they're supposed to do, and these people don't. And so you might expect different outcomes in the groups because their characteristics were different. Okay? And it could make it look as though inspiratory muscle training does something when it does absolutely nothing. So it's much better to leave them in the groups where they are. This does cause some problem. It does slightly water down the treatment effect. It'll make it a little bit smaller than what it would have been because these people didn't get treatment and these people did. But it doesn't completely reverse the effect. It doesn't create effects where none existed. The only thing it can do is slightly make your estimate a little bit more conservative, which is not such a bad thing, because if you still prove it works, then you can be doubly confident about it because it's a conservative estimate. Okay, the nerdiness is all over. So they'll either say everyone got the treatment they were allocated to, or we did intention to treat analysis, basically. So if you see those two things in a paper, it's a good thing. So randomised, blinded, not many dropouts, the groups were similar at baseline, concealed allocation, intention to treat analysis, and they should show you a flow diagram. So this is a flow diagram from a paper in my journal, which was about older people. I wouldn't know because I'm so young, but older people apparently get leg cramps sometimes at night, and so this was a trial of stretching right before people go to bed. So they excluded a few people who weren't eligible because they had other medical conditions. They didn't just have leg cramps, so they got them out of the trial. Then they screened these people and randomised 80, and so they got balanced groups, which also tends to happen at randomisation. But if the groups are a little bit imbalanced, it doesn't matter. Then, beautifully, no loss to follow-up in either group. So 40 finished the trial and 40 finished the trial in both groups. So this group did stretching just before they went to sleep and kept their other usual activities the same. This group also kept usual activities the same but did no stretches. So if there's a difference between them here, 6 weeks later, it must be because these people did stretching for 6 weeks. So these diagrams are pretty easy to understand, and they can show you if there were bad things, like lots of people dropping out of the trial. Okay, so what tools can you use to help you find this information and find it in a format that you can, in words that you can understand? One place you can go is PubMed, and I haven't given you the email addresses of any of these things because every single site that I'll talk about, all you do is you go to Google and you type in the name, and I promise you it's the first thing that comes up in the list. So go to Google, type in PubMed, and it's the first site that comes up. And it looks big and complicated, but the only bit you need to deal with is up here, and you just type in the words that you're interested in, and then you click search. Okay, so let's say you've heard there's a new vest, a trial of the vest versus the PEP mask, and you want to see if you can read up about it. So you type in cystic fibrosis and vest, because they're the only words you know, and you click search. And I'm sorry if this is a bit small to read, but basically what you see is a lot of papers, and a lot of them mention high-frequency chest wall oscillation, high-frequency chest compression, high-frequency chest wall compression, and you think, okay, that must be what, and I have heard someone say that that is what they call the best in these technical papers. So, and you think, oh, maybe I could put in words for PET mask as well. So you might change your search. I'll just make it a bit bigger up the top there. So this time you type cystic fibrosis, high-frequency chest wall oscillation, randomised trial, because Mark said that was a good idea, and PEP, because I know that that was what it was compared to. And then you search on that, and bingo, there's your paper. Okay, long-term multi-centre randomised trial, okay, that sounds good, of high-frequency chest wall oscillation versus positive expiratory pressure mask in cystic fibrosis. Excellent. What you saw on some of the previous ones is that there was free PMC article, free article, which means you should be able to click on it and read the full text. And more of those are popping up all the time, and journals are changing. There's a big campaign across the world where people say, all this research was funded by public money, by donations, by government, taxed money being sent to medical research. It was paid for by the people. It should be accessible to the people and not behind a wall that you have to pay a subscription to get it. Everyone should benefit from this. And so my journal is changing, and the first issue next year, it'll be free for anyone to read any paper. We've already got all free except for the last year, but we're changing that. We're getting rid of the last year and we're just making it free for everybody, and lots of journals are doing that. So if you used to find that you could never get the full papers, you'll see a lot more are becoming free. This one doesn't have that, but if you click on it, okay, so if you just click here on the title, then you get the one paragraph abstract, so the one paragraph summary in very technical language. You also see this button which says full text. So if you click on that, bingo, you get the full text copy of the paper and you can read the whole thing, okay? And usually that button wasn't particularly bright. Usually they're pretty bright and colourful because the journals want people to cite their papers. So if they're bothering to wear the cost and make them open access, they want, if it's free, they want people to know that it's free, and so they use it, because that's the advantage of it being free to the journal, is that people read it and cite it and use it. So they're usually really bright, colourful buttons. So if you see those, you should be able to get full text. The thing about PubMed is it's a little bit medical, as in doctor focused. A lot of the other professions aren't represented quite so well, and Google Scholar is a lot more inclusive, and so it works very similarly to PubMed. So you can just do a simple search. You could type the same search strategy in there and click the little magnifying glass to go searching. But it also has some clever options, and you can just fill in as many of these as you like. So you may not know the author's name, or you may not know the journal name or what year it was published, but you know that you're interested in inspiratory muscle training, so strengthening up the inspiratory muscles in cystic fibrosis. So you'd expect all of the words inspiratory muscle training to be in there. It might be training of the inspiratory muscles, or it might be inspiratory muscle training. You don't know the order that the words will be in, but they'll all be there. But these words will definitely be in this order, cystic fibrosis. So you can say that's an exact phrase, and you can put that in. And then you think one of these words should be there, random or trial or study. At least one of them should be in there. And then you can click search. And you'll find a whole lot of papers all about the effects of inspiratory muscle training in patients with CF. Inspiratory muscle training improves lung function and exercise capacity in people with CF. Inspiratory muscle training. And what you'll find if you spend the time reading all of these papers is that some of them say it's beneficial and some of them say it's not. And so then you've gone to all that effort and you think, boy, I still don't feel like I have an answer because not all the trials agree with each other. Wouldn't it be nice if someone would just take all of the papers and pull them into one document that just says, this is what the literature says about inspiratory muscle training in cystic fibrosis. And those documents exist, and they're called systematic reviews, and they're fantastic. And they're what I tend to read because I've got that exponentially increasing graph of physiotherapy trials. I can't read them all, but if I can read one really well-designed review that summarises all the evidence, then I know that I can save a lot of time. And you can too. And wouldn't it be nice if you knew there was a big, rigorous, unbiased group who would do this fairly and who would put a summary at the end in simple, plain language, not scientific jargon? Well, there is such a group, and they're called the Cochrane Collaboration, and they write these big reviews. So rather than reading all those papers that you found on Google Scholar, you could go here and you could type in, and once again, you don't need to web address, just put Cochrane Library into Google, and it's the first thing that comes up. So you type your little search in here, inspiratory muscle training cystic fibrosis, and click search, and here it is, a big review. So these people have laboriously gone through all the databases they can find, PubMed, Google Scholar, everything, found any trial to do with it, and pulled all the data and sat down and said, okay, let's fairly judge on balance what the evidence says overall. And so they give you a plain language summary, and I'll try and get you to the guts of it. So they found 8 studies with 180 participants, so a fair bit of evidence. So all of those studies would have had 2 groups randomly split. One group got inspiratory muscle training, the other group didn't. Okay, in this case, sometimes you're able to pool all the results. If all the studies use the same outcome measures, then you can pool the data and pretend that it's one giant trial with 180 people. They weren't able to do this because there's different ways of measuring lung function, different ways of measuring quality of life, and the different papers all used different methods, which was unfortunate. But they were done over decades, and systematic reviews didn't exist when the first trials were done. So that's why all different outcome measures were used, and it's a bit messy. And they can't, unfortunately, what they can't is make a strong recommendation. And if you look, we cannot recommend the use or not of this intervention. It may work, it may not work, and we don't have a clear picture from the trials. And the biggest problem is the trials that show that it worked, when you actually read the full review, the trials that show that it worked are very poor quality, only published as a conference abstract, not published as a full paper, so it hasn't gone through full peer review. So look, there's maybe a possibility that it works, but the more well-designed, fully published trials are not looking very positive. So they have to give you this middle of the road, and this is why physios wouldn't do it much in your clinics probably, because there's a good theory about why it might help, but we don't have any strong evidence that it really definitely does. So that's why we're pretty lukewarm on it at the moment. But at least you've found and got an answer and got an explanation for why you can't seem to get any physios to encourage you to do the training. The Cochrane Library isn't the only place that publishes these. So in my journal, the Journal of Physio, we also publish systematic reviews, and we also have a little plain language summary about them on the first page. So wouldn't it be nice if there was a place that you could go to find all the systematic reviews, whether they're done by Cochrane or done by anybody else? And for general medicine and for dietitians and other areas you can't, but for physiotherapy you can, and it's called Physiotherapy Choices. And so this is a free website, there's no subscription, or you don't have to put your name in or anything, you just go, it's free and you just use it. And guess how you find it? Go to Google, type in Physiotherapy Choices. So this database provides a catalogue of the best research evidence of the effectiveness of physiotherapy interventions. 3 sorts of research evidence are catalogued: clinical trials, so individual research studies; reviews, so the systematic reviews that we've just been talking about, that pool the results from lots of randomised trials; and then something you probably won't be interested in, which is major guideline documents. So if you're a physio working in the area, this is a document that pools the systematic review about inspiratory muscle training, the one about general exercise, the one about airway clearance, the one about hypertonic saline, the one about everything, and it's one giant document, and they're huge, and they're very hard to follow because they're full of scientific jargon. So you probably don't want those, but a review, if it's available, or if it's not, then read whatever the best quality clinical trial is. And the best thing about this site is when you do your search, you don't have to know particularly technical terms. So it says, to search for evidence about physiotherapy for a particular specific problem, select the appropriate term to complete the following statements. So these statements. You don't need to make a selection for every single one. And if your search receives too many irrelevant articles, you can try and put some more terms in, or if it doesn't find anything, then take out a few terms. But basically, you just try and complete these sentences. The health problem, and then you click on the pull-down menu, and it says, it's all in plain language, involves a broken bone or bony deformities. So let's forget CF for a minute. Let's say you got arthritis in your knee, and the physio told you should exercise, but your pain seems to be aggravated a lot, and you're wondering about maybe exercising in the pool, going to the pool and walking up and down, would that be a better option? Get some weight off the knee joint. So it doesn't involve a broken bone or bony deformities. You haven't had a knee replacement, so no joint surgery. It doesn't involve the brain and spinal cord. Affects muscles, joints or nerves other than the above. Yeah, that sounds like the most promising so far. It doesn't affect heart-lung circulation, kids. It does affect older adults, but I'm not an older adult, so I won't click on that one. So let's say you click on this one. Affects muscles, joints or nerves other than the above. And the next one, the symptom or difficulty experienced is, and it's pain, weakness, shortness of breath, all simple words that you can understand. So for your knee, it's pain. And the exercise you're interested in is exercise or other treatments in water. So there's all sorts of options there. Fitness training, coordination training, strength training, splints and orthoses, respiratory treatments, whatever. You're interested in exercising in the pool, so you click on this one. And then you don't even need to know the name of the body part, although knee is a particular term. But let's say your pain is here, you don't quite know the name of this little bit just here. You don't need to worry, you just click on the red one, shoulder, upper arm, shoulder blade. Okay, yes, it's in there somewhere. So for you, it's knee, and then you click on Start Search, and you get a whole list of papers. Now, the guidelines I told you you're probably not interested in. There's 2 systematic reviews, so you think, oh, that's promising, but neither of them they're both just about exercise in general and not specifically about exercise in water. So they're probably going to be fairly big documents that maybe mention exercising in water at some point, but it doesn't look as though it's the main topic. And then the first trial, a randomised trial of aquatic and land-based exercise in patients with knee osteoarthritis. Bingo, okay? And what you notice is, those things I told you before, randomisation, blinding, concealed allocation, intention to treat analysis, all those quality things about the trial. We've done the work for you. We've got 10 of them, and we tell you how many of them are met by this trial, and we put them in the order that from highest to lowest, so you can start at the top of the list and go, okay, this is the best quality trial. So you just work down until you find one on your topic. Lucky for us, it's the first one, and first one, and it's 8 out of 10, so that's good. So we click on that, and you'll find this trial. It'll tell you who wrote it, Lund, a whole lot of Danish or Norwegian people, and where it's published and so on, and then a big technical scientific abstract, and then a plain language summary, which is further down the page, but I've dragged it up. So it puts it in words you can understand. This trial randomly allocated people with knee arthritis to exercise in a physiotherapy gymnasium or to exercise in waist-deep warm water. The patients were in their mid-60s and the groups had similar characteristics at baseline. Both groups did their allocated exercise for 8 weeks. The groups had similar outcomes at the end of the 8-week program. So you're probably going to be just as good exercising in the pool, so you could give it a try because exercising on land isn't doing very well for you. When followed up at 3 months, the gym exercise group had marginally less pain, and on a scale of 1 to 100, it was only 8 different. So that's pretty small difference, probably pretty insignificant. However, discomfort during exercise was more than twice as common in the gym group. So a lot of people in that trial were suffering the same problem you're having of exercising on land. You can do the exercise, but it's aggravating the pain. So it might be making your knee stronger, more improving the flexibility, improving the function. You're able to walk upstairs better, but the pain is bad. And so the pool was probably a better option because most of the outcomes are the same, or the only one where exercise was different was a pretty 8% different. That's pretty small. Now you think, okay, well that really sounds wonderful, and I'd like to read more details about how much exercise they did in the pool, how many times a week, what sort of activities they did in the water and so on, and I'd really like to read the full paper. So if there's a full text option, we will put a link to it, but there's some journals that won't allow us to put the link because they say, oh no, we're copyright, we want to be behind the wall that you pay for the information, and so we're not going to let you put a link to full text anywhere. And so this is where I get racist. I really don't want to be a racist person, but I have to say those Dutch people are absolutely crazy. They have done what we don't have the guts to do, and they have taken all these full text copies on the paper and just put them up on the internet anyway for anyone to use. So they could get their pants sued off them at some point. But the biggest publisher in the world is Elsevier, which is a Dutch publisher, so maybe they feel like they've got some protection. But I think they're pretty brave, but while they're still getting away with it, we might as well take advantage of it. And so if you go to their website, which is Centre for Evidence-Based Physiotherapy, CEBP, in the Netherlands, so cebp.nl, and you click on search, and then you just put the author's name, so that was Lund, and click author, and then click search. Then you'll get all the papers, Lundberg, Lundgren, Soderlund, blah, blah, blah. Lund, a randomised trial of aquatic, blah, 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 versus land exercise. So there's our paper, click on it, and you get the full text. So there's another option. If none of those give you the full text, there is one other thing you can try, which is called Free Full PDF. And I'm not giving you the website because you already know how to find it. And so if you're interested in, I forget which example I used. Oh yeah, so say you've heard there's this new trial about hypertonic saline in infants, and you've got an infant with CF in your family, and you think, oh, I want to know what the results of that trial said, and I can't get a full text copy anywhere, then you could just type in this search box, infant and hypertonic saline, and then you'll get pages and pages of papers that mention it. But if you scroll down, you'll find the one, inhaled hypertonic saline in infants and children younger than 6 years, randomised trial. That looks like it. Click on it, and you can get the full text. So, and that PDF finder looks everywhere. It just crawls through the internet and finds it all. So how can you get research that's not published yet, maybe really cutting-edge stuff that's only just been presented at a conference? Well, conferences have started doing new things. At the latest European Cystic Fibrosis Conference, this private company was employed to do a summary of the best presentations at the conference. So they asked a bigwig doctor from the US to go and look at all the medical presentations and choose what was best and take photos of the slides and go and sort of recreate the slides. And then they recorded them speaking to the camera, talking about the slides that flash up on the screen and saying what was really good about these presentations. They got me to do all the physio, allied health ones. They got somebody else to do all the benchtop sort of technical research. And then they put together a big DVD, and you can watch and listen to people explaining what was good about these best topics, and you can buy that online. So if you couldn't go all the way to Lisbon, then you can just get a copy of it and watch the DVD. Now, I haven't seen it yet. It's still, I think, being all prettied up, but that should be coming out. The other thing, if you heard about it and you know who one of the authors are, then you can just find their email online and just write to them and say, look, I'm somebody with CF in New Zealand. I'm really fascinated about your research. I'd love if you could send me a copy or send me an explanation of what it found. And researchers are usually pretty thrilled by that, and not when you get one every week, but if someone's really passionate, then it actually makes you feel, wow, it's actually making a difference, and it's great if you can get it direct to the person. So I just say yes to just about all of those. That's about your only options for, other than talking to your CF team if they went to one of the conferences. And then the last one, which I really would encourage you to do, is where can you find trials that you could participate in? And here's where I get to slag off another country, the United States. Hate your guts, because I like America. My brother-in-law's American, so I can't really say that. But there's these new things called clinical trial registers, where all the trials that are happening get registered at the start. And there's multiple reasons for that. One is it should say this is the way the trial's going to be conducted, so that if the results, let's say one particular outcome comes out badly, the people who are running the trial can't just bury it and say, okay, we're not going to report that outcome, we're going to report all the positive stuff. But the fact that quality of life got worse, we're just going to pretend we never measured it. They can't pretend, because all the outcomes were registered on a site like this. So that's one advantage. The other advantage is you can go to the site and see all the trials that are happening, where they're happening, whether you might be eligible. It shows you the criteria you need to be in the trial, and the contact number, so you can contact email, so you can find the person and say, I'm interested in being in your trial. And warn them to sit down before you say that, because nobody ever volunteers to be in a trial. They have to be coaxed into it. So if you ever volunteer, you'll be very well treated, I promise you. So all you do is you just go to Trial Search, and they're all free. The American one's free, the Australian one's free. The thing that's good about, the Australian New Zealand one is free. And the thing that's good about it is it's the most comprehensive and the most complete. The US one has ambiguous bits in it and missing questions, and they don't police it very well. Our one is done really rigorously and really well. I actually walk past the building where this is done on my way to work every day, and I feel like going in and giving them a big sloppy wet kiss every day, because they just do this so well. And so you just type in cystic fibrosis. I just want to know what's happening in the cystic fibrosis trials, and there you'll get pages and pages and pages of them. So the first one, it's no coincidence, is one of mine. In adults with cystic fibrosis, what is the effect of therapeutic ultrasound? So I don't know if you've ever had ultrasound from the physio on your neck or your knee or shoulder or something. It's just like sound waves from a little machine that goes into the tissues. And that we're going to do over the sinuses to see if it can improve sinus symptoms in people with CF. It's very promising in sinusitis that's not due to CF, but hasn't been looked at in CF sinusitis, so that's our next trial. Then there's one about a randomised controlled trial of effects of early life exposure to general anaesthesia on neurobehavioural outcomes in kids with CF. So if someone said that your child might need a general anaesthetic for some particular procedure, and you want to know what the effect on neurobehavioural outcomes is, then that trial will be helping to answer that question. This one, physiotherapy services for CF patients receiving home IV. So the trial is you get your IVs, everyone gets home IVs, and they either get randomised to getting a physio or not getting a physio, and we see if their outcomes are any better. So that would be an interesting trial. And so you can click on the record and get you just click on view, and it tells you which hospitals are enrolling, how long the trial runs for, who the contact person is, all that stuff. Fantastic. You just go through pages of them and say, oh wow, this one interests me, and go from there. So that's it. Any questions?